started with the last rounds event of the 2016-17 academic year. Thank you all for coming out. New friends who I haven't met yet, my name is Jennifer Gardy. I'm the faculty coordinator for rounds here at SPPH, and I'm super happy to see you all this morning. Welcome. So we shall begin today by acknowledging that we're gathered here today on the traditional territories of the Musqueam people. The type of storytelling and learning that we are about to engage in has happened in this space for many, many years before we were here. So please take a moment to reflect on that, and for my fellow settlers, think what you might do as an ally towards reconciliation. Take a moment today and reflect on that. What to say about today other than it's going to be fantastic. Many of you were gathered here a couple weeks ago when we talked about the opioid crisis. We heard from a number of folks that were involved on the front lines, and it was an incredibly powerful event, and today's is going to be even more so, I think. We are again lucky to have an incredible group of peers from the community with us. We're going to be hearing from their stories and learning from them. And today it's all about solutions to the problem, innovative solutions. We have a couple of not so innovative bits of administrative minutiae to get through first before I introduce our speaker. There's the reminder that should you be joining us online, hello online, and wish to ask questions, you can do so with the SPPH Rounds hashtag on Twitter. For those of you that require continuing medical education credit, you may get said credit by filling out the online survey. You can find that on SPPH's Rounds page or at the survey link here. The learning objectives for this presentation, I won't read them out. I'll allow you to scan those with your eyes, but those will be the learning objectives that you're addressing in your CME survey. Business and conflicts of interest, nothing to declare. And so with that, I will turn emceeing duties for the event over to our fantastic colleague, Eugenia Oviedo-Joekes. Eugenia, apart from having the most difficult name to pronounce in all of the School of Population and Public Health, is another one of our superstar researchers who is doing incredible things in the community. Her work is offering really innovative solutions to the opioid crisis and ties in really nicely with the harm reduction talk that we had at the beginning of the month from Jane. So Eugenia, over to you. Thank you so much.
Thank you. Happy to be here. I'm not going to read all the acknowledgements, but just before I even start saying, even when it looks that I have this big role, I have a very small role, and a lot of people contribute to bring this small piece into play. And I want to particularly acknowledge the research participants that today are going to be taking over the second half of this presentation, Leanne, Lee, and Vincent. Yeah, I'm so bad at names, Jesus Christ. So I am excited because I don't have to talk so much, and I get to listen every time. We'll listen to the folks that are day in, day out living what we do and what we don't do. Is a learning experience, and it's a learning experience emotionally, and it makes research find its place in the School of Population and Public Health and in the university. So I will try within my Argentinian framework to be brief, if that is even possible. But I thought, without going too much through the evidence, and because today we're going to talk about, do we need this treatment in Canada? Of course, based on me dedicating my entire career to this, I believe so. But just a bit of history. Diacetylmorphine is a pharmaceutical grade heroin, and it is a stigmatized medication with a very good, powerful name, heroin. Oh, that's a very nice name. I would buy immediately without knowing what it is. So in the UK and in the 20s, they decided to make diacetylmorphine part of the addiction treatment system but what happened, injectable, but what happened is around the 60s, they had to put restrictions on how this is going to be provided because it was flooding the black market. It was difficult to keep patients in the community safe in a model where people were not paying attention to many other things that need to be part of the continuum of care. So although it continues being part of the UK model, it's delivered not under supervision, means you go to a pharmacy, you pick up your medication, and then you go home. And then at the end of the day, very few people are prescribing and very few people are receiving it. So in Switzerland, if you know anything about Switzerland, it's one of the most conservative places you are ever going to encounter. At 3 a.m. in the morning, people stop walking on the red light. There's nothing on the street, and they just stop. But they had an open scene with the heroin flooding the streets and everybody injecting. They had very good systems in place, and they are very pragmatic, and they decided to open a shop, a room, with a healthcare provider, and started to provide pharmaceutical grade heroin. So what we call the Swiss model, it was appealing and palatable for many other countries because it solved the issue of how we can have some control over who is receiving the medication, how it is prescribed. Not that I adhere or disagree, but that was the initial thought. So a bunch of countries joined this initiative, and none of them at the beginning were able to put in place heroin-assisted treatment without a clinical trial. So most of the countries that today have a program, except one, started with randomized clinical trials. So briefly, the current evidence is we have 7 randomized clinical trials. I will encourage you to go online and not to do this presentation about the science. I think few times in my life I've seen a treatment have shown so many times with randomized clinical trials, high quality, that show it works. The questions on why we're not expanding do not reside on the lack of evidence whatsoever. We are not able to convince policymakers to move forward, not from the science, not from the advocacy. I mean, I think we are today the closest we have ever been in Canada, but we're still struggling for people to just do it. And reporters come and ask me, why? I'm not going to put words in other people, but let me tell you, it's not the science. Let me tell you, it's not the willingness of the community. Let me tell you, yeah, there are barriers. It's not, resolving this crisis is not going to be cheap, and it's not going to be fast. So yeah, we need more money, and let me tell you, this treatment is not going to be the treatment that is going to solve this crisis. This is one small piece of the puzzle. The fact that there is so much resistance is kind of suspicious. We got the Cochrane review that is pretty much the Bible for all of those that do clinical trials, saying it does work. Shocking. Adverse events are consistently more frequent in the heroin groups because it's injectable compared to methadone. That's the reality. The main outcomes where we see that this is working is reduction of street drug use, illicit activities, retention in treatment, very important, and possibly mortality because the clinical trials are short. So it's with low incidence, with the numbers we see, but we don't have the science that can compare mortality. And the patient profile, those not benefiting from oral methadone or Suboxone or the oral medications. And people ask me, what do you mean with not benefiting? Well, let me tell you, if you're still using drugs in the street, what other indicator I need? It is, the first step is to keep people safe. And if you continue using, regardless of being or not being on methadone, means it's not working. Whatever we're offering you, we're not reaching. So when we talk about the supervised model care, what people think is the drug. And what we're trying to make everybody think is this is not just about the drug. This is about a way of meeting people where they are at, in a very small piece of the puzzle. Always remember, this is part of a continuum of care. So the supervised model of care, the first thing that we are trying to do is we provide the medication under supervision, means you will come 2 to 3 times per day. We will give you the meds. You will inject, sometimes with support of the nursing staff, but the nurses cannot push the medication due to liabilities. And you will stay there, and if you're fine and everything's fine, you just go home or go no home, because again, this is a very small piece of the puzzle, and there are a lot of things that we Canadians need to fix in our community, not just providing pharmaceutical grade opiates. The supervised mode of care ensures the safety of the patients. If anything happens, there's people there that can help. And also, the safety of the community, because the opiates cannot leave the site, so they're not in the street. But based on the heroin pills in comparison with all the drugs that we have now in the street. So it's kind of like outdated, that part from my presentation. Then if you think about coming 2 to 3 times per day, it's 2 to 3 times per day that we have an opportunity to build a relationship with someone. 2 to 3 times per day, I'm going to see you. 2 to 3 times per day, I'm going to come and you're going to see me, and you will say, how are you? Waiting for that moment of the conversation that can get to the point where I can offer all the care that you might need. So that's the third part, important part of the model of care, of the supervised model of care, is to connect you, to have an opportunity to offer comprehensive care. I'm hoping to not put words on our participants, but coming 3 times per day is not fun. I suffer from chronic headaches. If I need to come 3 times per day to a clinic to take my medication, I am going to die in the street. No one comes 3 times per day. So it is a commitment to yourself and to the program to come 3 times per day. So, and we have it there, and then what can we do? So the opportunity to offer comprehensive care is a big part of what we do. When people ask objectives of the treatment, I keep asking all the time, so when people get clean of drugs, just with the language, we know where the mentality of the person is coming, but it's important that we do not get angry when people do not understand. When I started working on a heroin-assisted treatment, it did make no sense to me giving methadone to people, because, what? You just don't use and that's it. So I studied my PhD, that was 20 years ago. I meant a lot. But I want to say, today I'm advocating for, we need to have a bigger conversation of decriminalize, to offer safe medication. So when you see somebody that is really far away, remember that this lady here was really far away at some point in her life, and today is advocating for prescribed heroin. Safety, relationship, and access to care. Our first step is to keep people safe. That's our first aim, keep people safe. And we work from there, depending on where you're at. Of course, we have objective treatments, but the main objective is to meet you where you're at. What do you need? And then we need to be cautious, because I need a lot of things that the public healthcare system doesn't have for me. I go through the public healthcare system like many of you. You're young, so you're very healthy, but when you need to face the public healthcare system, there's a waiting list, there's not enough for everybody, and there are decisions to be made. So sometimes people are going to need things that we don't have, but you still can come here 3 times per day and go through this together with the sense that we're not leaving anybody behind, and we are doing what we can together. The latest study we have is the Salome study that we did because we don't have diacetylmorphine pharmaceutical heroin licensed in Canada. With the same objectives, but I am going to start jump in a bit because I really want you to hear from the participants. I brought this slide. This slide has 15 years old. It's 15 years old. Professor Wim van der Brink came to Spain to give a presentation on the Dutch clinical trial. And he brought this slide. Nothing has changed from there. We still think that easier and cheaper options like oral methadone, buprenorphine, slow-release morphine, things that are easier, are the best, but are not the only thing that you should be having. I do not know any other illness where I go to my physician, and I went yesterday, and I said, this is my problem, and she put on the table 4 options for me. She made a recommendation, and I said, yeah, this is probably the best thing for you. I don't want to do that. Okay, you can do this other one. Why I'm offered that option, and people with severe opioid use disorder are not? That is discrimination. Is there a need for this treatment? This is the cumulative recruitment that we didn't sell in the trial. The green line is the people what we included in the clinical trial. We had a sample size of 202. Sorry, that's the pink. The green is the people that didn't meet the prerequisites. Means we opened the lines. The first day we had 130, thank you. 130 people the first day called. We brought a beer, and allow me to derail because you need to understand the need in the community of this treatment. 130 people called that day. We opened 4 places by phone and on site. Because we got 130 people, we couldn't put an order without people feeling they need so much this treatment that you cannot. You need to make it as transparent as you can, because we are working in a world of injustice and unfairness, and every single thing we encounter makes us feel that again, we are the subject of discrimination, stigma, being left behind. So we brought a peer, a person respected in the community, and we randomly assigned those 130 an ordered number. And then the next day, the 131, and that's it. And we got to 600 calls. Of those 600 calls, 500 qualified for the study, and we could only include 202. You need to think what it means for frontline workers. This is real-life clinical trials. This is you telling somebody else that needs this treatment, no, you're not getting in. So when we do clinical trials, there are people behind every single number that you're working with. Our outcomes speak for themselves. I will only show you 2. That is the reduction in street opioid use from almost daily to an average of 5 days in the prior month. And our retention and treatment puts to shame any other addiction treatment that you're going to find. 80% retention in any way you want to look at. So means this outcome, that is one of the most important indirect measures of if this treatment is working or not, is showing you have daily an opportunity to do better and to continue working with people. I am going to jump a bit to the almost penultimate slide. The highlights of this study are not indifferent than the other 6 randomized clinical trials with hair-assisted treatment. Participants improved. All adverse events that happened during the study were managed by the healthcare providers. Yes, there is a risk associated to the use of injectable. Tell me about it. We are seeing that daily when people are injecting in the street. But when you are given a pharmaceutical grade medication, that is a dose that the physician and yourself have come to an agreement that is effective and safe, and you come every day and inject in front of people that know what to do, when something happens, we are there to help. So yeah, this is, and we have shown again that this is a treatment that is an alternative. So moving forward, we have the evidence. Please, policymakers, they know this. Heroin-assisted treatment or with hydromorphone has a very small but very important role in the addiction treatment system. We need to go through this crisis together, and denying the expansion of this small piece of the puzzle starts to feel bad. This is not okay. We can right now do it, and people need to let go and understand that this is something that we could add for people to be reached by the healthcare system. And offering the care and the premise of meeting patients where they are at is a very important component of the injectable treatment, because we need to offer a continuum of care. The continuum of care is very important. Do not get hooked on the medication. The medication is a little portion of everything we do. But for the same reason, do not get hooked on the medication and just give it to the people. So in the moving forward, and I will invite now Jan, Lee, and Vincent, if they can come and share with us. Thank you very much for doing this. I hope you can appreciate how kind and generous they are to be with us here today. Thank you very much. You may sit. So I pass it to you, and I think that the topic of today is, do we need distinction and why and what do you think?
Thank you. Hello, everyone. My name is Vincent here. I'm one of the patients at Salome. I guess it's changed its name now. Opioid-assisted treatment.
You got 3 names.
Yeah. Yeah, things moving along. I'm not sure where to start. So, yeah, I'm gonna pass this over to you. You guys are a little bit more experienced than I do.
First of all, let's remember one thing. We like to call it, everybody likes to say free heroin, free government heroin. Heroin's never free. Never free, thanks. And it takes a piece and part of your future past. So I always want to start by saying that, because I find it funny that everybody goes, oh, you get government, it's government grade, it's not free, right? I don't see anybody going, well, we get free insulin, right? And yet we are considered, our disease is considered ongoing and chronic, never ever to be cured. And we get hung up on the moral things, but Salome, what it does is it stops you from that chaos, what it did for me. It stops us from the chaos of having to go and score your dope and having to go and live in a crime-ridden area, and men and women have got vastly different things going. Like, I never had to look and realize every time I walked in to go score dope that who was gonna, who I had a beef with or anything. However, the sex trade is constantly there, and we're all from different backgrounds, right? Like, I sat in this theater and I'm university educated. I got addicted through morphine, through a doctor's prescription. I like to call him Dr. Wrightswell, because he wrote really good prescriptions. and duplicate too. And unfortunately, it dragged my whole life. Like, I was from a small town where I had my morphine script for years, nothing ever. He left the country. And by that time, my husband had also gotten a morphine script, which was only supposed to be in case I ran out. And you know, lo and behold, addiction happens, right? And within 6 weeks, I was at Carnegie. Is anybody in Hastings? Middling dope to get my heroin, because heroin was more available. I lived my life like that, with just a few credits away from a master's degree in a back alley on Hastings, okay? And within 6 weeks, my children were older. I was very lucky that my children were older and I was able to raise them. So I don't think that didn't have to be apprehended, and we didn't go through that, thank God, which I see a lot of. But I lived like that for 3 years. I was homeless for 3 years because I didn't have the ability to get up and go and get an intent to rent because my self-respect was so low. I didn't want to walk into a welfare office because I was a junkie. It was out. My life came crumbling down when in my small town I came up and I stood up and I said, I'm an addict, I need help. Boom, that was it. Lost my job, lost my friends, and it was like on Hastings, right? And at first it's all glory, because like you're all of a sudden realize that there's a bunch of us. Hey, wait a minute. You know, how can somebody with a master's degree, with somebody that with grade 2 education, you're sitting in an alley shooting up, there's gotta be a link there. There has to be, I maintain them. But then thank God, because I don't think I would be alive. I know I wouldn't be alive right now if it wasn't for Salome. I weathered a lot of storms. I weathered when girls were disappearing from corners. And we had Picton down there, you know. And my husband weathered every year he would go into be incarcerated because he had to support our habit, right? And then you have the big thing of where he gets out and he's healthy and I'm not because I've had the burden of, you know, most relationships don't survive down there. But it took then somebody from Insight that thought I was more worthy than I did decided to tell me about this program. So they said, go meet this guy named Kurt down at the bank. Sign you up. And then it's like, yeah, okay. And I wasn't going to go. And then basically had to drag me down there, and I went. And I said, so what is this about you get? You're going to give me drugs? And they told me about everything, and I was like, yeah, okay. And I thought, this is way too good to be true. And then they said, yeah. And then they said, okay, well, thanks a lot, bye. We'll be in touch in the next 6 months. What? You know, you just offered me a way out and you gotta wait 6 months? Yeah, really good guys. And 6 months came, and by that time, my husband had come out, and I basically said, you have to do this program because I'm not gonna go in and I'm not gonna, because I know I will screw up and end up being kicked out because you need some. And that's the way you have your back, you know, your partner's back. Okay. And we got ridiculed like, you know, guinea pig, government guinea pig. You know what they're doing to you in there, right? And it was like, okay.
What happens when it ends?
Yeah, what happens when it ends? And that was always hanging over our head too. Like, do we have to go back? You have that moment. You know, we've had this stability in our life, and now it's like, well, thanks for showing us what this does now. See you, bye. It's like, no, you can't do that. You gave me my life back. You know, I'm living in an apartment, pay rent, I get up, I do these things, it's all normal. And it gave me my self-respect back, where all of a sudden I'm standing in front of you guys talking, like, I used to wear 3 or 4 hoodies, you know? Yeah. And because I didn't want to be noticed. And the nurses would say, it's time for your injection, Leanne. What? And it's like, and Lee would have to go, no, they're trying to be nice, No, they're giving me dope now, right? And so it was, you know, like, it stopped the chaos, and now all of a sudden we have the opioid crisis. And I watched a 36-year-old woman, very similar story to me, living in my back alley, just like me, and between, I guess, about 25 people a month ask us now about getting into the program, and we have to say there's no spaces available. Well, that woman didn't come up and ask me this month, so I went in the back alley and I asked. She died of a fentanyl overdose. The only difference between her and I is this program,
Yeah.
and that's not right. It's not morally, ethically, spiritually right. Because she wasn't on the streets as long as I was, she doesn't get it off her a way out. I've regained my relationship with my kids. I have my marriage. I've had, built really good friendships. You know, there's people, you don't get friends when you go down there. It's not a party central. You have people you do dope with and people you don't do dope with. And you have to be very careful in that. And so when somebody offers you a little bit of sanity, where you don't always have to be watching over your back, you don't have to be, you know you need this drug, but what are you putting in your arm? Is it gonna kill you? You know? You're gonna tell me that if I am so dope sick where I am vomiting and stuff, and you're gonna tell me, don't do that, you gotta shoot up alone. And there's nobody around that I trust, I'm gonna shoot up alone. We can Narcan these people all we want, we have to give them the safe drugs when they're all better and from the overdose. We've got to, they're gonna go back and they're gonna buy the same shit.
Yeah.
That's killing them. And the only reason it's coming to the forefront is because all these, as we call chippers, weekend warriors are dying in their bathrooms at their mom and dad's house or at their apartment, and that's why it's coming in and hitting you guys in the face. We always knew who the chippers were. You guys didn't. We did. They came
Yeah.
down every weekend.
Yeah.
And they're the ones that are dying because they don't, you know, and we see it down in our place because the regularity is, people are having to. I know that I would be dead. My husband would probably be incarcerated when that would happen if I didn't have the program. And I think that every addict should be, it's not for everybody. I mean, it was really hard for me for the first 3 months. It was this man right here that used to drag me 3 times a day as I would argue and scream at him and say I didn't want to go. And he's like, no way, you're not packing it in. You know?
It's hard to show face.
Yeah. It's a lot, you go through a lot of emotions, but because you pay the price for free heroin, you pay a heavy price. So I think that our policymakers are hung up on the word heroin. They get weirded out, you know, but if you go, well, I'm on that 70 morphine, that's wonderful, darling. That's nuts. So I'm so glad that helped. You know, but say heroin and they're free.
Vincent, you were saying that it was hard to show face. What did you mean?
Well, when I first started, it's I'm not used to sharing my just me being in a place with other people that I'm not familiar with, right? You know, I can go in the back alley and hang out with everybody. You know, I know everybody there. You know, they're all in the same place, right?
You avoid places where other addicts are because it's dangerous. So then all of a sudden you guys are telling us, come on over, there's a bunch of addicts waiting here for you. It's like, no way. No, we don't do that. We do it with the people we feel, the people you do dope with, the people you don't do dope with.
That's right. And it's also the nurses and stuff like that. You're not used to having people care about you. You know, like, yeah. All these people that are here. I can't talk.
Thank you. Thank you.
When you get your life back, you start in the care again. And it's like when they did that first program.
Yeah, here you.
What was that program called? You were in it too.
Which one?
Naomi.
Naomi. Yeah, that's where they came and said, here we go, have a really, oh, you're all stabilized? Okay, see ya, back on the street. And that's what he was in, so he was not in town.
I was in that Naomi study, and sure they gave it to us for a year, and then after the year they kicked us out.
Yeah, that was it. Cut off.
When I went into that program, my habit was only $20 a day. And I got out of that program, I had it was $500 a day. I couldn't
Yeah.
afford it.
Yeah.
They didn't watch us titrate, we're addicts, okay?
Yeah.
Like,
You know?
nobody tells me, like, an addict to himself doesn't say, well, that's enough, no, I want more and more and more. I want the whole bag, don't give me half a bag. So I started doing crime, one thing led to another. Ended up in jail, get out all healthy again, and then, you know, like, in jail, everybody thinks, okay, I'm not gonna go back to using heroin, everybody has the right mind, but when you get out, in reality, it's, well, like,
One of the
who's out
first
there
things
for
you
you?
do.
Mhm.
You know, you have dope stashed in your shoes, or, you go see the dealer when you get out, because that's the only thing you know.
Because they give you usually they give you a bus ticket. It just always just got me crazy when we would get out of jail. They gave him a bus ticket and back down to Hastings.
Yeah.
Wonder why he used, you know? Like, you know, sitting there in prison graves. Wonder why he used. You know? And then our system shuns anybody that comes out and asks for help. I don't care what anybody says, they shun them. All of a sudden you're put in a shithole SRO.
Oh my
You're
gosh.
treated like a junkie. And it's always like, in a junkie, like, there's difference. There's addicts, there's junkies, everybody's got their own code, right? And
I
you
invite
don't, you all of a
anybody.
sudden administrated on your welfare check because you don't know how to use your welfare check because you're an addict. You know what? Addicts know how to use their welfare check. They string it out so they can actually support their habit, right? And so it's demeaning. That's why it wasn't a big issue to go get
Yeah.
housing.
Food, you use all your money for dope, but food and stuff like that, it's, you gotta eat, drink, you gotta clothe yourself. How you gonna do that? It's all crime, you know? People go out and they're boosting this and that, or they're selling it to do the dope. And
So,
I don't know, I just thank God that where I am right now.
So when you got us on, what did that do? When you did that do?
I finally got a place to live. You know, I haven't had a place to live in probably 16 years, and then now I got a roof over my head. I got my own washroom and my own bed. I get, you know, I wear the same clothes for probably 2 months on end until I could, you know, until I could get up enough nerve to go someplace and get changed.
Yeah.
You know, that's-
And that's what I mean, there's not any help in the sense of like, when the first, like, it doesn't take, when we get the chaos, that chaos, now we're exposing the chaos that we lived, that chaos is all of a sudden no longer there because you've given us what causes us to go like, and have to support our habit. It's taken care of. And then there's a lot of emotions that you go through because you got a lot more time on your hands.
Yeah,
You know, like all of a sudden you're getting emotions back that you haven't you stuffed down.
yeah, that's why I find it hard to talk to you.
And I think everybody is sitting there.
Excuse me, can I ask some questions? So from your perspective, moving forward, you know, what would you suggest to the government?
Okay, we need more, I got 300 names in my apartment back home of people wanting this program. We don't have the place to put them,
Facility.
the facility to put them.
Crosstown cannot provide this.
Crosstown cannot provide this.
There's only so much room.
We've got 126 there, and we're going through renovation, very small clinic, very small clinic. They don't even have the staff room
So
there.
is a capacity issue.
Mhm.
It's on a rotation where, you know, you're in for a certain amount of time, and then you go out, and then somebody else comes in, right?
Yeah,
You know, the next
half
group
hour.
comes in, right? You know, so that they can facilitate as many people as they can, right? You know, but, the size of the facility is just too small, you know, like, she says she's got, what, 500-600 people that she did it, or she got
I live one block. These people stop me in
every
one
day,
block.
every day.
Every day. We
When
feel
can I
bad,
join?
right? So I
When
started
can I join?
taking their names. And then Kurt told me, wait a minute, we gotta find out whether or not they wanna go on hydromorphone, because the big thing is, no, they won't wanna go on hydromorphone. They want anything that's gonna save their life and stabilize them.
Yeah.
But we don't have the bricks and mortar, and we had a lot of barriers from federal. Now, we talked, they're cutting the red tape a little bit, but they promise a lot of things when they're face to face to us, but they don't really come through. Like, it's really great to hear our story, but yet, I have yet to see one extra person in our program.
The hydromorphone doesn't need a federal approval because it's licensed in
It's easy
Canada.
to get, yeah.
The diacetyl morphine does. So in terms of a barrier on how to obtain the medication, the hydromorphone could be given right now. As a matter of fact, there is one Dr. Christy Sutherland that has started one patient outside Crosstown Clinic as part of her supportive housing, and she has a patient on hydromorphone. So
One.
she has shown, yes, one, but what
One.
she has
That's
shown is that you can do it. That is, she went to Crosstown Clinic a couple of days, got our protocols, and started a patient. So it's not rocket science.
I have people that are willing to finance another clinic, but then there's this, well, they can't finance the other clinic because they're an advocacy group. Well, then we need the pharmacist. Well, then I got the pharmacist. Well, then we need the doctors. Well, I almost got the doctors. You know, so what next, guys? You want the bricks and mortar too? You know, and it's, yeah, it's one hurdle over another. But the
Yeah,
fact,
we take a question from Chris.
Yeah, first of all, thanks so much for sharing your story. It's really takes a lot to do, and it's just awesome that you guys just a clear demonstration of really taking control and making a difference. So I really appreciate it. I guess looking forward, seeing downtown and sort of having some family experience down there, like how important do you think it is that this is expanded? So let's say someone from up north or someone from a small town or Kelowna can get the treatment there so they can avoid the chaos downtown. Like how much does say in that chaotic environment, like getting out of that, how much does that hamper? Could you see even better outcomes if you weren't
oh, I mean,
forced to live
hydrogen-
down there, if you could stay in your home community and get the treatment? And how much does staying downtown to get the treatment actually hinder even the bigger successes that
For
you
the
could have?
Sunshine Coast.
Yeah.
My addiction was in the Sunshine Coast. When I moved, like I said, the 6 weeks
Yeah.
downtown, if I could change that,
Yeah.
I would.
Because I see it as like a trap. People come down and then
Oh, yeah,
the
it's-
services are only there, and then it gets other things. It
There's
just
not
worsens.
social housing, and there's a, you know, there's the rents are really high, and, you know, I think that my life would be, I think I wouldn't have the medical issues that I have now. I think that we wouldn't have the criminal issues that we had, you know, that if we could provide them in a small town. Now, the 300 names that I got were just from that one block, okay? So we have to start somewhere. I don't think there's one, doctors can actually prescribe the hydromorphone anywhere.
Yeah.
So maybe there should be a bunch of doctors meetings and coming to Crosstown or having, you know, but we're still hung up on the stigmatism of free heroin. Free heroin, oh my God.
Following up with that is, we have this model that is across town. There are many ways that you can be providing this medication and make it suitable to the patients you're seeing and the community where you live, as far as you maintain the 3 core aspects of this treatment, and is to keep people safe, to build relationship, and to connect with services where they can get comprehensive care. As far as you maintain those 3 things, you know, for example, in Spain, that didn't really go further because people stopped injecting, so injectable is a room in a hospital. You need nothing because hospitals, as you know, have a different slow barrier for pharmacy and etc. Nobody messes with the hospital. So you can have a room in a hospital. Granted, a lot of people are not going to go to hospital, but who knows? You can have in a community clinic. In the Netherlands, there are a standalone big Crosstown style clinic, Another very small clinic with nothing, but 2 blocks from there is a Professor Center. First you and then the gentleman back.
Thanks, Lee, and thanks, Eugenia. It's really nice. So I'm a PhD candidate here and also work at Insight. And one of my questions just is like, I really agree with the expansion of diacetylmorphine and supervised injection programs, but I also really see the need for those programs to be within a supportive network of other services. So one of my questions is like, to what extent can we ask for these type of programs within a broader context of social services that, such as housing and things like that? So like,
We have have you been to Crosstown?
I haven't been to
You should come to Crosstown because we have social workers
Yeah.
and then we have all sorts of things. Right now it's kind of up in the air. But what we need is more places, you know, like you exactly say. I think
So, when we first got there, it was just the beginning, you know, like, it's like anything with, when you first started, you have to adapt and, you know, tweak this, tweak that, you know, because we're human beings, right?
some of us are 2-minute people,
Yeah.
in and out.
Everybody's
We don't
different,
want,
right?
yeah, we
You
don't
know?
want like, you don't wanna talk to nobody, just come and get my crap and let's go. I don't wanna go and talk to a counselor. You know, where me, I'm 35 minutes in there chatting away, you know, and he's waiting outside. So, yeah, so I think there's like, really astounded me is there's different kind of clinics all over the Netherlands, like she said, and I think that's what, we're diverse, right? I think that like the way Vincent and Lee got along is because of the incarceration and the time in jail. They have a whole set of different problems,
Yeah.
and also,
We relate differently.
yeah, and not problems, what's the other word for it? Qualities because of their time, right? So that's the way they should, you know, for guys, I think that there's also should be a women's clinic. But I mean, that's all a great thing. Right now, it's about saving lives. This is all wonderful and we've got to save lives. What is it, 1,000 people now? And I've gotta keep remembering that it was that woman in the back alley. It's that 16-year-old boy or 18-year-old boy that was trying it for the first time in his mom's bathroom. The opioid crisis has taken over. It is made the reason to have this, it's pushed it to the forefront, right? We've got to get over the stigmatism, so we don't have time for it, or we're going to be losing people on top of people down there. And that's exactly, people are testing for fentanyl that are apparently that are smoking pot, they're spraying it. You know, like, it's just the car fentanyl now, right? And you're telling dealers not to make money, because most soulless people are the scary meds. You know, that's where they're gonna make money. And if it makes money, like one dealer said, come on, Leon, 10% death rate and I'm still making money. You know, it's like, okay, I don't wish your karma on you, or anybody, you know? But, yeah.
So before we go to the other question, just a comment on what you said. Of course, connecting with services, what cannot be happening that we wait to have all the other services and then give the heroin because we feel very shy of giving heroin unless you have the other services. We have the services we have, period. We need to do so much better than we do. But wait to have all the services in place to start providing safe medications, it's never going to happen because we do not live, we live in the world where the bad people win elections. So if we are waiting for everything to be in place to prescribe pharmaceutical grade heroin, we're going towards extinction. So let's slowly but together move in the full front, one step at a time, and not leaving or trying not to leave anybody behind. So I'm pretty sure it's not what you meant, but I'm using your question to say this over and over.
But on that point, maybe
Okay.
I ask you to clarify, moving forward. So we just, let's say we expand the capacity
Yes,
and more people in the program.
yes.
You're just stabilizing the population.
What do you mean by stabilizing?
You're not moving forward.
Okay, wait a minute there, I know what you're saying. Wait a minute there. I
So
never,
by being on the program.
I'm pretty sure she can answer that one.
I don't wanna
Question
be
to,
three
I cannot repeat that.
yeah, I don't wanna be in have to go to a clinic 3 times a day, nor does my husband. So we have and I really don't wanna say this because I don't wanna give you the wrong idea and all of a sudden say, you don't need that clinic. I, in the future, see myself completely clean,
Yeah.
and that is what my goal is. But please, don't take that, like, all of a sudden, we don't need that clinic. That's why I don't mention it. Is that, most of us, once we get that little bit of sanity in our life, we want more of it.
Yeah.
And we want our lives back.
That's right.
Therefore, that, if you're asking that most people, yeah, it's great, it's 3 times a day, I don't have to look for my drugs. But that's not what we want in the long run. We're not mentally, physically, spiritually supposed to be 24 hours a day medicated. And I believe that you're spiritually, you end up wanting more. So for me, I know for my husband, I don't know, Ben, if that's what you,
I definitely don't wanna be.
you know, I've got a step down method that I'm gonna be doing.
So what are the numbers of people, having gone through the program that become clean?
First of all, we don't speak about clean. We don't use this to say that someone's clean. She can say it about herself, but we don't talk about
Just
people.
using the word.
I am not clean. I'm
Yeah.
taking a medication every day, so I'm not clean.
So
But
it's
that's how I am.
semantics.
So if you look at how the countries where this has become a problem, and has been a problem for 15 years, treatment with injectable doesn't account for more than 10% of all the substitution treatment. So once you are able to reach the people that needs this treatment, the numbers stay in a 10%. Maybe at the beginning, we will need to grow and maybe represent a bigger name, like a 20%, based on the numbers that we have from Salome and what we know is on methadone. But this is supposed to have a small role because, as she said, it's a lot of work. You need to commit to the clinic. And Vincent said, I was not really keen on coming 3 times per day to be with a bunch of strangers. Treatment is not for everybody. If I today was needed to inject opioids to carry my life, I will be able to find another way than going to Crosstown. So this is a treatment for a specific situation where you encounter yourself in a pinch. And this is a way to bring you back and regain the trust with the healthcare system and work from there. We succeed sometimes we do not. But as they were saying, the goals needs to be theirs, not mine. It's not what I want to be seeing happening. It's what Leanne, Vincent, and Lee want to see happening in their lives. And yes, if you don't want to be medicated, I have no problem taking daily a medication that helps me to sleep. So I'm fine. I don't need
Some
to be
of us
paid.
make it out. Some of us, I just know one thing. Some of us have gotten clean. Actually, quite a few of us. But the people that have went back out, they're dead.
Yeah.
So
Okay.
there is a
And
gentleman
some
in the
of them
back
back
has
on
been
that.
trying to ask a question, and I'm sorry.
Thank you. First of all, I'd like to commend the 3 of you for sitting up in front there and sharing your stories. I know how difficult it is and the courage it takes to get up there and share your story. I had my own run-in with addiction before too. I was just wondering if you had a message specifically for the youth, what would the message be?
So a message for the youth.
Stay in school.
Me and I have 6 kids with each other, and 5 are not addicted. 1 is addicted. And I
They've
know.
all tried it.
yeah,
They've all tried it.
it doesn't happen overnight is my message, okay? It's very insidious, okay? And people will tell you, I didn't get addicted to the guy with the trench coat going, psst, psst, first one's free. He had a coat, but it was white,
Yeah.
okay? That was the guy that got me addicted, right? And it doesn't happen overnight. It's not like all of a sudden one day I was partying and then I was on Hastings Street. It's a long process.
And it
Yeah.
affects everybody.
And I think that I maintain that, look around you. Like we've got, I used to be really, I'm really concerned with the youth down there, and we take our time out and talk and do the scared straight. But, the choices you make in life are just, it's scary. Like, you know, if I could turn back time but now I have a different message. Don't use alone. Too many of them are dying. Like, I didn't use the drugs that my kids have fiddled around with. And everybody, I started at 13, we started at 26, right? So, and everybody always thinks he got me into it. No, other way
It's a
around.
personal choice.
Yeah, it's a personal
It's an
choice.
individual choice. I don't know what I would say. I had a horrible upbringing, right? You know, not everybody does have that horrible upbringing. Some people have the greatest upbringing in the world, but they still have the ability to become addicts. You know what I mean? Like everybody does. You know, it affects everybody. You know.
What we need to do is expose our children to what's down there. Those scared straight walks that I was telling you about, take them down there. Don't make it so apparent that I had a great upbringing, come from a very well-to-do family, and that wasn't going to happen to me. Yeah, it's right. You know, you don't, smart people don't get addicted. Right? Oh, boy, did I ever grow up.
We can take a last question there.
I'd like to address a friend who's concerned. I work in tobacco education, actually nicotine addiction. I'm a tobacco educator. And what I'm learning is tobacco addiction is a pediatric disease which extends into adulthood. So 80 to 90%, almost 9 out of 10 kids start smoking before 18 years old. And they'll end up smoking for the next 16 to 20 years. And I've also learned that heavy drug users, about 80 to 90% also use tobacco. So it's all interrelated. So that's why I'm here now. Because I want
That's the thing that Crosstown everybody wants to quit smoking.
Yeah.
Too, I'd like to just mention Dr. Eugenia for emphasizing the role of meeting patients where they are. That is the spirit of motivational interviewing, which is what we do in tobacco education. We meet the patient at their need. So it's known by the acronym CASE: partnership, acceptance, compassion, and evocation. And then you can go and access the continuum of care. The first rule of harm reduction is to keep the patient alive enough to be sane, stabilized, and much healthier to access this holistic, comprehensive continuum of care, which I think they are in place.
What a beautiful way to finish this talk. Thank you very much. It's 9, so we are closing. Thank you so much.